So this is a modified foot and ankle ultrasound. The foot and ankle complex is incredibly complex, and people need to really be guided by patient symptoms. I don't want to go ahead and cover everything in foot and ankle. I need everyone to be aware of the fact that there are so many structures that are possibly affected. I'm just going to cover the major structures and the major things that can potentially go wrong in the foot and ankle. But again, like at all areas of ultrasound, you need to expand your study according to patient symptoms. So that's really important to be aware of. So we'll start with the plantar aspect. I'm going to ask our patient just to curl her toes underneath and stretch out the bottom of her foot. I'm going to look at the plantar fascia. So you can see here the calcaneus, the heel pad above, and the medial insertion of the plantar fascia here. Again, a standard measurement for the plantar fascia is around sort of 3 or 4 millimeters. Anything more than that, you're starting to get into plantar fasciitis or thickened plantar fascia. But this looks beautiful. Again, make sure you scan the insertion side to side. You may need to go to a transverse section. Again, looking at that calcaneus in transverse with the plantar fascia insertion overlying the top. Again, something to be aware of in musculoskeletal ultrasound is anisotrophy that we mentioned on an earlier talk. If your transducer varies even slightly, even just 3 or 4 degrees from perpendicular, you can see how anechoic the structures become. Again, this is indicative of fasciitis or tendonitis, tendon tearing in other areas of the foot and ankle. So it's really important to make sure you maintain that perpendicular scanning plane. Make sure the entire area appears echogenic. And again, the heel pad slightly hypoechoic on top of that. If this starts to look anechoic in any way, or if it demonstrates increased blood flow on power Doppler, you can start to be concerned about an inflamed heel pad or edema in the heel pad, which is something that's relatively common, particularly in athletes. So again, just going back to a sagittal section over the calcaneus, again pushing out into wide scan just to get that extra amount of information either side of the perpendicular. Again, beautiful looking plantar fascia here. Attachment here normal. Again, you can see the anisotrophic effect of this very, very proximal portion of the plantar fascia as it attaches onto the calcaneus. But you can see as you heel toe back and forth that fills in and becomes echogenic. So you can see that that's perfectly normal, and that's just the hypoechoic area is just artifactual in this case. So the plantar fascia extends all the way through the arch of the foot. Again, making sure you scan side to side. We're looking at this structure here, nice and smooth and continuous. If it's interrupted by a hypoechoic ovoid structure at any point along its length, you can be suspicious of a plantar fibroma. Some patients feel them in the bottom of their feet because you can see how superficial the plantar fascia is reaching as it becomes more distal. So much so that sometimes people feel these fibromas as quite hard structures underneath their fingertips, and it feels like sometimes that they're walking on pebbles. So that's something to be aware of clinically. Again, making sure we follow this structure all the way distally, comes right up superficial as we reach the toes. At this point, it starts to spread out and it attaches across to each toe. So the best way to look distally at the plantar fascia is to go back to the calcaneus as your landmark. Again, heel toe the probe to make sure that you fill it in so it's nice and echogenic. So this is its proximal insertion. We're going to head down the foot into the arch. You can see the plantar fascia here. Let me just put calipers on so I can delineate that a little bit better for you. That's the structure we're looking at. Again, 2.9 millimeters, perfectly normal. But you'll see as we move distally, if you look carefully, it's going to start to branch out. This is the plantar fascia here. I'm heading down the foot, I'm into the arch now. You can see it's starting to become more ovoid as opposed to more spherical. As I keep coming down, it's spreading further and further out. It's becoming thinner, it's coming closer to the top of the surface. until we get all the way down towards the toes, and you can see how spread out it becomes. So it's really important to make sure as you assess, particularly in this transverse section, that your eye scans all the way medially to all the way laterally and doesn't just stay focused on that central portion of the plantar fascia, because you can have quite extensive and distal fibromas sitting right out either side. So it's really important to be aware of that. So while we're at the plantar aspect of the foot, we'll go ahead and we'll take a look at the Achilles tendon. We're headed now to the back of the heel. Again, you'll see a different aspect of the calcaneus. Here, this echogenic line is again being representative of bone. Let me just zoom this up so we can see a little more clearly. And again, you can see the, let me get rid of this, the fibrillar pattern of the tendon stretching right out and attaching onto the top of the calcaneus here. Again, be really wary of musculoskeletal ultrasound of anisotrophy. Heel toe the probe, make sure you get rid of this hypoechoic area. If it doesn't disappear, then you can start to be suspicious of tearing or tendinosis. But again, really make sure you have a dedicated effort to fill in those blank areas of echo before you become suspicious. Again, the proximal measurement for Achilles tendon, you don't want it to be, more than about 10 millimeters or so. This is, way below that, perfectly normal. You can see here, deep to the Achilles tendon, there's a small fat pad here, and this is an area where fluid can collect in the retrocalcaneal bursa. Sometimes if that becomes fluid filled, it can become inflamed, and it will light up on power Doppler if that's the case. So always make sure that you put power Doppler on that bursa back there. And again, similar to plantar fascia, make sure that you scan all the way medially to laterally, covering the entire aspect of the tendon, and follow it all the way up into its muscular insertion more proximally in the calf. So again, you can see as we stretch more proximally, the Achilles is going to bow down and start to get a little deeper and start to blend into its muscle here. Again, in ultrasound, assessing everything in two planes. We're going to go back to the distal insertion and we're going to look in a transverse plane now. Again, be aware of anisotrophy. Make sure you heel toe the probe, getting rid of all this blackened artifact here. So make sure you're at 90 degrees. And again, a little bit of fluid in the retrocalcaneal bursa here. Again, a little bit of fluid is quite normal, just as a cushioning effect on the tendon. Power Doppler again, just making sure that there's no hyperemia surrounding that small amount of fluid. We're going to extend slowly, proximally into the calf. Again, be aware that the Achilles tendon is quite an ovoid structure. So make sure that your eye doesn't just affix in the center portion of the tendon here. Make sure that you really are assessing out laterally and medially, making sure that you're covering all aspects of the tendon. Again, as we move proximally, you'll see the Achilles tendon start to spread over its muscle. Quite normal. Let me just take it off the zoom so we can appreciate that a little more effectively. You can see the tendon gets really wide over the top of the gastrocnemius muscles there at the back. You can see it gets really thin proximally, stretching all the way out. Something to be aware of too, sometimes that when the Achilles tendon tears, or a muscle in fact, or any tendon tears, it can be associated with a fluid collection. Something to be aware of just sitting underneath the Achilles tendon. Just stay really cognizant of any fluid that might be in the area. So into the gastrocnemius muscles we come now, medially, laterally, soleus underneath, and the Achilles tendon is completely gone now. We know we've covered its entire length because we're up in the muscle bulk. Again, just scanning down one more time. being really sure we've covered the entire area. We've been sure to put power Doppler on. We've checked that retrocalc bursa. All the way down distally. Okay, so let's go ahead now and have a look at the medial ankle. So if we can ask our lovely assistant here to roll up onto her left side so I can see the inside of the ankle. Okay, so looking medially in the ankle now. Starting, 10 centimeters or so. Yeah. Starting about 10 centimeters or so proximal to the medial malleolus. Taking a wide approach here to what's called the tarsal tunnel, similar to the carpal tunnel in the wrist, but in the medial ankle. And we can identify a number of structures here immediately. They call these tendons Tom, Dick, and Harry at the back, and that's a nice way to remember it. The posterior tibial tendon, flexor digitorum longus tendon, and the flexor hallucis longus tendon at the back. In between the tendons, you'll see the tarsal tunnel itself, made up of the posterior tibial nerve with that typical honeycomb appearance of a nerve, with all its punctate hypoechoic spheres in there. You can see the posterior tibial artery, and when we go back to live, you'll see that pulsating away, and the paired posterior tibial veins next to it. So something to be immediately aware of in the medial ankle is that tarsal tunnel complex. Again, let me just highlight where we're looking. This area here. Similar to the carpal tunnel in the wrist, anything that's going to intrude on space in this area is a likely cause of pain and tingling in the toes. So anything that's impinging on that nerve, whether it be soft tissue neuroma, whether it be a ganglion cyst, whether it be varicose veins, all of these things are relatively common to see in the tarsal tunnel, something we need to be aware of when we're assessing that region there. So just something to be aware of. You can see stretching out above the tarsal tunnel encapsulating it is the retinaculum. Looks a little bit like a ligament extended right over the top there. Again, you want to make sure that that's intact and creating a superior margin over the tarsal tunnel. It can become interrupted, it can become discontinuous, and you can get fluid collections here. So really important to make sure you assess the retinaculum lying over the top here. So let's go and focus on our tendons now. Let's look at the posterior tibial tendon, first of all. It's the guy right at the top here, right here. Okay. Again, we're going to start quite proximally and we're going to follow it all the way down, again, heel toeing as we go, making sure it stays nice and echogenic. As it goes around the malleolus, it can be difficult. Again, underneath the retinaculum that you can see here. Following it all the way down distally. You're looking for any fluid around the tibial tendon. You can see here there's a little fluid here, quite normal. It's quite a inferior structure in the body, so fluid can collect here normally. Again, be sure to put the power Doppler on, make sure it's not associated with any hyperemia or inflammation. Continue heel toeing until you see the tendon fan out and attach distally. This is it in sagittal now, distally. Tendinosis is quite common at its distal attachment, something to be aware of. A little bit of fluid here again, quite normal, and a nice fibrillar tendon above. I find tendons of the ankle easier to assess initially in the transverse section, and then to come to a sagittal to make sure that you sweep through medial to lateral. But I find transverse a good place to start. So heading back now proximally in the tendon complex. You see here flexor digitorum longus with its muscle at the back. We're going to do exactly the same thing. We're going to start proximally, and we're going to follow that tendon distally. Heel toeing all the way, making sure it stays nice and echogenic. again, following it all the way down distally, and then coming to sagittal. And following it back up. Flexor hallucis longus at the back, because of its depth, is a little more difficult to define at times, but again, it's important to be aware of the echogenic tendon here and its more hypoechoic muscle around it, which can be a good landmark. It's obviously a lot larger than the tendon itself, so sometimes it's easy to isolate the muscle and then really focus your eye a little bit more superficially to the tendon here. And this sits back in its calcaneal groove back here, below the tarsal tunnel. We're going to follow flexor hallucis again, heel toeing all the way, down through its muscle, to the groove here. There it is here. All the way underneath the foot. There's the flexor hallucis longus, as the name suggests. Flexors the big toe. So you need to come all the way down now to the big toe. You can see flexor hallucis here, above the sesamoid, all the way down, and attaching onto the big toe distally. If you like at this level, sometimes it helps to do provocative manoeuvres if people are getting pain when they point their toes, quite common in ballerinas. You can just have the patient flex their toe back and forth, see if they can reproduce their pain, and watch the tendon move back and forth in its sheath. You want to make sure it's a nice, smooth, gliding motion, and there's no bunching and no fluid collection, which can be indicative of tenosynovitis. And they're the major structures medially. So let's go laterally. So if we can roll over the other way so we can see the outside now, we're almost done. So laterally, we're going to be looking mostly at the perineal tendons. They're paired tendons that share a common sheath, the peroneus brevis and the peroneus longus. Peroneus longus is the more superficial one, the bigger one here proximally. Peroneus brevis is the one at the back here with the peroneus brevis muscle, similar to that flexor hallucis tendon muscle complex. It looks similar, muscle at the back, nice and hypoechoic, the more echogenic tendon next to it. The way I remember which is which is peroneus brevis, B for brevis and B for bone. Brevis is closer to the bone than longus is. That's how I remember it. So it's something to keep in mind if you think like me. So again, we're going to follow brevis and longus down around the malleolus. You'll see here underneath there's a number of fibers that stretch out medial to laterally between the fibula and the calcaneus of the heel. This is the calcaneofibular ligament. It's nice and thin, nice and echogenic, perfectly normal. It creates a bit of a couch for the perineals to sit on as they roll over the top. So it's just something to keep an eye out for as you head more distally with the perineals. You can see they stay paired as they head down the ankle, and they start to branch off just distal to that malleolus. And at this point, you're going to have to make a decision as to which one you're going to study first. So let's go with brevis, this guy. Following it all the way down until it attaches onto the metatarsal. Again, just looking at that distally in sagittal, coming all the way down from proximal, expanding out and attaching onto the metatarsal. That's peroneus brevis.
Which metatarsal is this?
The fifth metatarsal. So we come back up to where they started to separate, and this time we'll follow peroneus longus as it dives down into the tunnel, following it deep, headed down, still deeper, bringing your focus down, making sure you keep all your parameters with the tendon. And again in sagittal you can see it the longest diving deep here. So again, I find looking at these tendons more proximally and transverse, it gives you a good overall view first of all, and it also is good to orientate yourself as to which of the perineals are which, how it associates with the calcaneofibular ligament that we looked at, and then heading to sagittal for more information. That's the way I would recommend it's done. That's it. So that's just a basic overview of foot and ankle. Again, a lot of things to take in all at once. But again, they're the major things to be aware of in the foot and ankle. And that's it.